Hello everyone. Now we'll go in the surgery section with the liver disease. So I have written some important topics that we're gonna do. First of all, we'll do the hepatoma. So hepatoma is short from like primary hematoma. Hepatoma is hepatocellular carcinoma. It is seen in the cirrhotic patients in the United States. And what will this hepatoma present with? Right upper quadrant pain, weight loss, and alpha fetoprotein will be increased. And we can do CT to see the location and the extent, and we can resect the tumor accordingly. That is the surgery. So this is about the primary hepatoma. Next we have metastatic cancer of the liver. So it outnumbers the primary cancer of liver in United States, and it is mainly how we can identify it with a CT scan, CT abdomen, and we have to do follow up with the primary tumor. We have to see if any tumor marker CEA is increased in patients with a history of colon cancer. So it can come as a primary cancer being colon cancer, so it can come as a metastasis from there. And these metastatic growths are slow growing, and they are mainly confined to the one lobe. And what we'll do, we'll resect it, and we can also go for radio frequency ablation. Next is hepatic adenoma. Hepatic adenoma is mainly a complication of females on OCPs, and it can rupture and bleed massively into the abdomen, and so it presents with a diffuse abdomen pain and hypertension and tachycardia. CT is diagnostic, CT abdomen, and we have to stop the oral contraceptives. And patient who present with hemorrhage, they should be going under transcatheter embolization, and signs of shock, if are being seen, they have to manage with a emergency surgical exploration. So in nutshell, we saw alpha fetoprotein mainly associated with primary hepatoma, CEA associated with metastatic tumor from the colon cancer. We did CT contrast to define the location and extent of the tumor. And in primary hepatoma, mainly we resect if it is tumor-free anatomic segment is left behind, that we only resect the affected lobe. And in the metastatic tumor, the resection is done if there are other metastases and it is surgically possible, and the primary cancer is still relatively slow growing. And the main thing about hepatic adenoma is we are worried about the bleeding that it causes into the abdomen, and we'll follow up with the CT for any other mass. We'll stop the OCP. And next come the pyogenic liver abscess, the infectious part. It can be pyogenic and it can be amoebic. So first of all, pyogenic is mostly a complication of biliary tract disease, or there is any choledocholithiasis. Choledocholithiasis is stones in the CBD duct, and that can obstruct the secretions, and that can lead to stasis and bacterial infection, and that can cause ascending cholangitis, and that will present as infection will present as fever, leukocytosis, and there will be right upper quadrant pain. So what we'll do CT, or we can do ultrasound also, and we'll do percutaneous drainage. Now what about in the amoebic abscess of the liver? It is mostly, first of all, common in male, and mainly in the people who are traveling to different countries, mainly endemic countries where Entamoeba histolytica infection already is endemic, like it occurs there. And how will the patient present it? Patient will not present as acutely as amoebic abscess, uh, as a pyogenic abscess, and we will mainly do serology to rule out and to do the diagnosis. And what other things that we can do? We can start the empiric treatment, and if clinically suspected, we can suspect it clinically, and we can start the treatment with the antiprotozoals. And mainly in the antiprotozoal also we give metronidazole, and that is quite effective. And if improvement is seen, we don't have to drain the abscess, okay? It will be taken care of if we see the improvement with the metronidazole. So it is mainly common in Mexicans, the amoebic abscess, and we do serology for amoebic titers, and we prescribe metronidazole, and that's much it about the abscess being both amoebic and pyogenic. And now comes to the important part, jaundice. Jaundice, we all know, is elevated bilirubin, and there should be more than 5 milligram per deciliter bilirubin, serum bilirubin, to cause any detectable changes in the sclera or the skin. So what are the causes? That first of all we'll go with the hemolytic causes. So hemolytic causes of jaundice that cause hemolysis. So what we'll find in it, there will be bilirubin will be raised, but not very raised, and all of this will be unconjugated bilirubin, and there will be no elevation in the direct or conjugated fraction, and there is no bile in the urine. And in peripheral blood smear, we can go for we can review any drugs the patient is on, and bone marrow biopsy if it is needed in the extreme case. Now these are the hemolytic. What are the hepatocellular causes? That is the infectious causes, mainly by hepatitis. So hepatocellular is mainly we'll see both fractions of bilirubin raised, unconjugated and conjugated, indirect and direct, and high liver transaminases will be increased, AST and ALT, and there will be always also increase in the alkaline phosphatase. And now what we'll do the serology studies, serum studies. And the third type is obstructive jaundice. It is mainly elevation of both fraction of bilirubin, and there will be a moderate amount of elevation in transaminases. Alkaline phosphate will be highly elevated, and what we'll do for the workup, we'll do ultrasound that will look for the dilatation of biliary ducts, and see where the obstruction is, whether it is by a stone or is it by a tumor. So first of all, if it is stone, that is obstructing the CBD, and the stone is, or it is seen in gallbladder, it is obstructing its mouth. And so what we'll do, for if we are suspecting obstructive jaundice caused by stones in females that is obese and is multipara, has come and is more than 45 with high alkaline phosphatase, and we see dilated ducts on the sonogram due to the obstruction, and non-dilated gallbladder can be full of stones. So what we'll do ERCP. ERCP is endoscopic retrograde cholangiopancreatography. It is used to confirm the diagnosis, and with this we can do sphincterotomy and remove the common duct stone, and cholecystectomy should be done if it is required in case of prolonged hospitalization due to complication. And we can consider for an intra-op cholangiogram and CBD duct exploration if we are not sure that the stone has been removed or there is any residual stone that has been left. Now in case it is obstructed by the tumor, most commonly it is adenocarcinoma of the pancreatic tumor, that is adenocarcinoma of the head of pancreatic pancreas, and or there is adenocarcinoma of ampulla of Bader, or there is cholangiocarcinoma. So these carcinomas can obstruct this duct, and what we'll see on ultrasound, we'll see there is dilated gallbladder, and then we can go for CT scan. And pancreatic cancers will usually produce obstructive jaundice and are big enough to be seen on the CT. and if CT is negative, we don't find anything, we go for ERCP. Now, ampullary cancers or the cancers of of the common duct, they produce the obstruction when they are very small due to their location. Okay, because the location is such, if they've obstructed this, everything will be obstructed. So although they are small size, they may not be seen on CT. So that's why we suspect ampullary carcinoma when jaundice coincides with the anemia and there is positive blood in the stool. So endoscopy will show these ampullary carcinomas and cholangiography will show the intrinsic tumor arising from the duct, and it will give like apple core like appearance. And what we'll do for the workup, we'll do endoscopic ultrasound to identify and diagnose tumor. We'll do percutaneous biopsy if required, and normally it's not indicated because it can seed the abdominal wall with the tumor. And if the cancer is suspected and tumor is identified on CT or ERCP, we resect in patients who don't have any contraindication, like there is no metastasis or other masses revealed, and it's benign and can be removed. And sorry, or it can be a pancreatic cancer, that is also very important part, that is very aggressive, and normally it's diagnosed at a late stage. That's why it's more of a palliative treatment. Early stage lesions are still resectable by the Whipple's procedure, so that is pancreaticoduodenectomy. And ampullary cancer and the cancer of the lower end of the common duct, they don't have good prognosis. Only there is around 40% cure. So this was the main about the cancers. So if you find a case where there is hepatocellular jaundice and we suspect that is infectious in nature, so we'll go for the serology and try to see which type of hepatitis it is. And if we see a patient with a gallstone and but now he presents with the jaundice, we'll see alkaline phosphatase to be increased and it appears like an obstructive jaundice case. So we'll start with the ultrasound and we'll see for any dilated intraducts and any extra hepatic bile ducts which are dilated, and we'll visualize the stone if there is any. And the next step after this ultrasound will be ERCP to relieve the obstruction. So it is both diagnostic and therapeutic, and cholecystectomy will eventually be performed. And if the patient presents with a weight loss and we see there is thin walled gallbladder and we are worried about the malignant obstructive jaundice, so mainly caused by tumor, and will show a distended bladder as a ominous sign, and the gallbladder is thick walled and non-pliable. So we'll do CT scan abdomen to assess for the mass, and if it is non-diagnostic, then we'll go for the ERCP. And if there is any malignant obstruction of the biliary tree from outside, like we discussed, mass of the head of the pancreas, that is adenocarcinoma, or intrinsically there is cholangiocarcinoma of CBD which appears like a big mass. So the location is likely to have discrete mass visualized on CT scan, and ERCP we can do, which is diagnostic. And malignant obstruction is normally cured in early stages by pancreaticoduodenectomy, that is Whipple's procedure. And in case we have GI bleed and there is suspicion for the malignancy, and we suspect it's ampullary cancer, and so we'll do the endoscopic biopsy. And if it is limited stage, we can go for the pancreaticoduodenectomy if it is an early stage. So now we have mainly gallbladder. We will deal with the acute cholecystitis first. We know gallbladder stones already major biliary tract pathology. They can get lodged in the gallbladder or lodged in the common duct, mainly in female fertile 40, and most of them are asymptomatic, so we don't do any procedure for that. And so we'll start first of all with the first thing, which is biliary colic. Let's go with the biliary colic. It is the typical pattern of the pain associated with cholelithiasis and chronic cholecystitis, and it occurs when the stone is temporarily occluding the cystic duct, and it is described colicky because it occurs in the waves in right upper quadrant and radiates to the shoulder and back, and it is often triggered when the patient has fatty foods and will present with the nausea and vomiting, and there can be this episode can be self-limiting, typically within half an hour, and it is easily we can easily abort this with anticholinergics. And what we'll do for the diagnosis, we'll go for right upper quadrant ultrasound, and that will tell us if there is any gallstones, and if there is any obstruction, we can go for elective laparoscopic cholecystectomy, and after, of course, viewing all the pros and cons. Now next is acute cholecystitis. So acute cholecystitis mainly start as biliary colic, and the stone remains in the at the cystic duct until there is inflammatory process that develops, and that leads to the obstructed gallbladder. And what will now pain will become more constant. There will be fever, leukocytosis, and it can now lead to peritoneal irritation, and we'll see on ultrasound gallstone and thick walled gallbladder, and there will be pericholecystic fluid. Okay, pericholecystic fluid. And on HIDA scan also we can do on HIDA scan very specific. We'll see the tracer uptake in the liver and the common duct and the duodenum. But if it is an occluded gallbladder, then we won't see it. And management is mainly NPO, IV fluids, antibiotics, and cholecystectomy can be performed if it's an urgent case. And percutaneous cholecystostomy is best temporarily when the patient is very sick and he or she is infectious, and we don't want to get into surgical risk of spreading the infection. So another important point is acute ascending cholangitis. So it is a more morbid disease than cholecystitis because the stone has now reached the common duct, and it will partially occlude the lumen and will lead to ascending infection because the secretions will be inhibited, so it will lead to an ascending. That's why it is called acute ascending cholangitis. Mainly in people who are old and much sicker, it will be high temperature around 104 to 105 with chills, with high WBC. There will be bilirubin will be increased mildly, and key finding that we'll see is alkaline phosphate will be very high, and something called Charcot striae is seen, that is fever, jaundice, and right upper quadrant pain. This is Charcot striae, and if we add two more symptoms, that is altered mental status and hypotension, then this all becomes Raynaud's pentad. So these are the symptoms, and on ultrasound what we'll see, dilated duct, and but we mainly go for the clinical diagnosis, and what we'll go for IV antibiotics, emergency decompression of the common duct, and this is performed via ERCP. We know it's both therapeutic and diagnostic, and we can also go through the liver by percutaneous transhepatic cholangiogram, and also in any severe case we can just explore the CBT surgically, and we can go for the cholecystectomy. Now this was all about the acute cholangitis, and now we'll come to the next, which is biliary pancreatitis. Biliary pancreatitis is when stone becomes impacted distally in the ampulla, and the obstruction of both pancreatic and biliary ducts. So the stones often pass this spontaneously, and they produce mild and transitory episode of cholangitis, and they also present with the pancreatitis because its secretion is also stopped. So we'll see elevated lipase, amylase, and then in ultrasound we can see gallstones in the gallbladder, and we medically manage it with keeping patient NPO, NG suction and IV fluids, and we'll go for the elective cholecystectomy. So this was the main gallbladder associated. So I'll just take one line each. So we know gallbladder mainly cholelithiasis is there, and in obese female, fertile and 40 more important risk. And we know there is something called biliary colic, which is a very specific pain due to cholelithiasis, and which occurs in the waves in the right upper quadrant radiating to the back and the shoulder, and it is increased with the fatty foods causing more nausea and vomiting. It is mainly self-limiting, and we can give anticholinergics for it. So, and we'll diagnose if the with the ultrasound we'll see for the stones, and we can also go for the elective laparoscopic cholecystectomy in severe cases. Now acute cholecystitis is also the one which starts with a biliary colic because there is stone obstruction, and now the stone can remain in the cystic duct, and the inflammatory process will usually develop into an obstructed gallbladder. So it will be the gallbladder mouth is closed by the stone. So there is constant pain, fever, leukocytosis, and in severe case it will lead to peritoneal irritation. And on ultrasound we'll see gallbladder, thick gallbladder wall, and pericholecystic fluid, and HIDA scan will show the tracer uptake in the liver, common duct and duodenum. And management is mainly with keeping patient NPO on IV fluids and antibiotics. Cholecystectomy, in the case it becomes very severe and unable to manage conservatively. And percutaneous cholecystostomy can be done temporarily in the case patient is very sick and we don't want to operate with the surgery right away. And that because cholecystostomy will relieve the pressure from the build up of the secretions in the gallbladder. Now there is ascending cholangitis, which is producing partial obstruction and ascending infection in the common duct within much systemic presentation with a high fever, high WBC count, and there is Charcot striate, there is Reynolds Pentat, there is ultrasound which shows dilated ducts, and we are giving IV antibiotics, we are decompressing the CBT, which is life-saving via ERCP, and we also do percutaneous transhepatic cholangiogram, and we can go for surgery directly exploring the CBD if we are not able to treat the pathology right away. And then the next thing is biliary pancreatitis, which mainly occurs due to the stones impacted distally in the ampulla, and it will obstruct the both pancreatic and biliary ducts. So it will lead to present with cholangitis infection and the pancreatitis infection. So what we'll give, we keep patient NPO, angiosuction, IV fluids, and we'll go for the elective cholecystectomy if required. And so that's how we manage mainly. So now we come to the pancreatic disease. So we know pancreatic disease can be acute pancreatitis, which can be acute, and that can also turn into acute severe pancreatitis. So first of all, acute pancreatitis mainly seen in alcohol patients or gallstone obstruction. And what will happen, mid epigastric and mid abdominal pain after a heavy meal or alcohol the patient is taking again and again. the pain is constant and it will radiate straight to the back, and it will be associated with nausea and vomiting and retching even after the stomach is empty, so that can lead to tears in the mucosa. And there will be tenderness and mild rebound in the upper abdomen. Serum lipase is very specific. Amylase is also increased, but lipase is very specific. And we'll see serum hematocrit level to be rising because the volume is decreasing, so it will be concentrated, the blood. So due to hypovolemia, hematocrit appears to be rising, and what we'll do, we'll rest the pancreas by keeping patient NPO. We'll go for nasogastric suction. We'll give IV fluids, and I will give IV narcotics for severe pain. And when it converts into acute severe case, then that is has much more morbidity, and it can lead to pancreatic necrosis, and accompanied by severe hypovolemia and hyperglycemia and hypocalcemia, leukocytosis. The patient appears very ill and will be very fast admitted into the ICU, and will closely monitor for the volume resuscitation, and will give mechanical ventilation if required, and we'll mainly go for post pancreatic enteral access and total parenteral nutrition if required. So the mortality is high, and it can be predicted by the Ranson criteria in the acute severe pancreatitis. Now Ranson criteria, it is both at the admission and at 48 hours. So at admission, the age more than 55, glucose more than 200, WBC more than 16K, and LDH is increased more than 350, and AST, the transaminase, is increased more than 250. So this is at the admission. Age more than 55, there is glucose more than 200 milligram per deciliter, WBC more than 16,000, LDH more than 350 units, and AST more than 250 units. So now at the 48 hours, what we'll see the hematocrit will drop for more than 10% from the admission. We'll see blood urea nitrogen increased more than 5 milligram deciliter from admission. Calcium will decrease less than 8. Partial pressure of oxygen will decrease less than 60. Base deficit is there more than 4 milligram per deciliter, and there is in need of fluid resuscitation for more than 6 liter over 48 hours. So this is the Ranson criteria at admission and the 48 hours. So you have to revise it and you have to learn it. So other scorings are also include like Apache, that is acute physiological assessment and chronic health evaluation, or SOFA scores, sequential organ failure assessment. So but we usually go for Ranson. Now there is something called pancreatic abscess. So when it will happen, when there is suppurative pancreatitis. So it occurs around 10 to 12 days after pancreatitis, and it appears with fever, leukocytosis, and on CT we'll see fluid collection, and we'll manage it with percutaneous drainage, imipenem and meropenem for typical gram-negative bacterial infection, which occurs mostly. Open surgical drainage and debridement is done to prevent for extensive abscess formation and the further necrosis. Now there is something called what occurs after the abscess and after the ischemia is pancreatic necrosis. It occurs post severe pancreatitis and is very difficult to manage. So normally the best thing is we'll surgically do necrosectomy. We'll remove the necrosed part, and the patient does well after that. And we have to wait for around 4 weeks before the debridement of the dead pancreatic tissue if sepsis is not present. So this is important. And hemorrhagic pancreatitis can occur when severe pancreatitis erodes in a vessel, and that leads to the anemia, and it appear as a complication. So clinically it is recognized by two things: the Gray Turner sign and the Cullen sign, and it is diagnosed pancreatic necrosis at CT scan. So periumbilical bluish discoloration is the Cullen sign, and Gray Turner sign is on the flanks. Okay. So this is important about pancreatic necrosis. And then we have pancreatic pseudocyst. Very commonly we discuss about it. It occurs after pancreatitis secondary to the trauma to the pancreas, or there is any pancreatic ductal injury, and but after 4 to 6 weeks of that, the pseudocyst will develop. It is just a collection of pancreatic fluid outside the pancreatic ducts, and mostly in the lesser sac, and it can cause compressive system symptoms, like it can compress the stomach and present as early satiety and vague discomfort, and you can see a palpable mass. And then we to diagnose, we'll do CT abdomen, and treatment is mainly dictated by the how long the pseudocyst is there, the age of the pseudocyst, and its size. So if it is small, less than 6 centimeter, for less than 6 weeks, with no complications, so we can observe it. So this is important part. We'll observe less than 6 centimeter, less than 6 weeks. And large cyst, which is more than 6 centimeter and present more than 6 weeks, and present with some complication like obstruction, bleeding, or infection. So we'll do internal drainage into the stomach with endoscopy or surgical cystogastrostomy, or cystoduodenostomy, or cystojejanostomy. So we'll just drain this cyst. So now the next important topic in pancreas is chronic pancreatitis. This is more common in alcoholics because there is repeated episode of pancreatitis, and that leads to the development of calcified burnout pancreas with steatorrhea, diabetes, because pancreatic beta cells are also destroyed and necrosed in the when the infection happens, and there is that leads to diabetes, and that it also causes epigastric pain. And the diabetes and steatorrhea are usually controlled with insulin and giving pancreatic enzymes, but the pain is very severe and is mostly resistant to most of the drugs, and it is very debilitating to the patient. And we can do ERCP to see any obstruction and dilatation, and we can treat it, and we can go for if there is any drain required for pancreatic duct, we can go for Pasteur's procedure, that is lateral pancreatico-jejunostomy. And in the case of so that is mostly all about the pancreas. So in a nutshell, if there is a classic alcohol-induced acute pancreatitis, give the pancreas rest by keeping patient NPO, and go for nasogastric suction and IV fluids and analgesia. And if there is very acute alcoholic pancreatitis and very severe, and there is Ranson criteria, there is at least 8 of the Ranson criteria present, and we are predicting it to be highly motile case, and there is high morbidity, and so the mainly and the chances of being converting into a pancreatic abscess. So we go for the broad spectrum antibiotics for the abscess if it forms, and serial CT and percutaneous drainage for it. And pancreatic, if the necrosis occur, go for the surgical necrosectomy. And in case the abscess can develop in the recovery phase of pancreatitis also, so we'll diagnose it with CT scans, and we'll mainly treat with antibiotics and percutaneous drainage. So pancreatic cyst can also appear like two things, like it can have two presentations. So small cyst with brief duration, let it get observed, or large cyst with long duration, we drain it. And We can do internal drainage with cystogastrostomy, cystodynostomy, and cystogegnostomy. So that's all about the pancreas. And also I like to add just a small thing about umbilical hernias, and in that we'll discuss about umbilical hernia. So all abdominal hernias can be repaired, and they to avoid the intestinal obstruction and strangulation. And asymptomatic umbilical hernia occurs less than 5 years of age, so we'll let it go spontaneously. There is esophageal sliding hiatal hernia, which is not a true hernia, so that we can wait for it to resolve. And a hernia which is irreducible and needs emergency surgery, so that we can prevent the strangulation, so we do the elective repair in that, because and it will appear as irreducible hernia, the strangulated one. An early surgical repair of hernia is generally we recommend it for preventing strangulation only. So umbilical hernia in children less than 5, let it go, let it resolve spontaneously, do the observation, keep monitoring. An umbilical hernia in children at age 5 will require primary repair. Now, even though when the patient is asymptomatic, he should not be exposed to the risk of bowel incarceration or strangulation. So all routine unilateral first time hernias are to be repaired by open or laparoscopic approach with a synthetic mesh, and laparoscopy is often favored, we know it's often favored for repair of the recurrent inguinal, bilateral inguinal, and incisional hernias. So the main surgical emergencies that we come to know is incarcerated hernia and the strangulated hernia, where the blood flow has been compromised and there is a evidence that there is a bowel ischemia that's going to happen. So this was the main thing. So thank you, hope you enjoyed the class.